we will be starting shortly.
Okay.
Yeah, perfect.
Thank you.
Mr. Afiq, can we start now?
Now we have 30 attendees.
Yeah, Dr. Veena, are you ready?
Yeah, can.
Okay, sure. Hi, a very good evening and welcome to the final week of the hematology webinars. The topic for today is thrombosis and antiphospholipid syndrome. We're very privileged to have two esteemed hematologists with us, our chairperson, Dr. Veena Silvaratnam, and our speaker for today, Dr. Sivakumar. So a little bit of introduction about Dr. Veena. Dr. Veena is currently a hematologist and head of clinical hematology research lab at Hospital Ampang. She obtained her MBBS in 2005 from University Malaya and graduated with the Dean's List Award. She then obtained her MRCP UK in 2009 and then went on to do her hematology fellowship subsequently. She also did an attachment at the Hammersmith Hospital in London from 2015 to 2017 and has been in Hospital Ampang since 2017. Dr. Veena has been involved in multiple research and publications across many international and also local journals. She's also the committee member for multiple local CPGs, which include the one for thalassemia, myeloproliferative neoplasms, and also COVID-19. So without further ado, I'll pass the floor to Dr. Veena to introduce our speaker for today, Dr. Siva.
Thank you very much for the very kind introduction. A very good afternoon, everyone. I've been given the task to chair the session today entitled Thrombosis and Antiphospholipid Syndrome. And I'm happy to introduce Dr. Sivakumar, who is going to be our speaker today. So Dr. Sivakumar is currently a consultant hematologist at Pantai Hospital, Kuala Lumpur. He obtained his MBBS at Manipal University in 2006 and then subsequently went on to do his master's in internal medicine in UKM from 2010 to 2015 and joined the hematology fellowship soon after in 2018. He completed his training in 2021. He's currently, as I mentioned earlier, working at Pantai Hospital, Kuala Lumpur, but he was formerly based in Hospital Chancellor Tengku Mutsir UKM, HUKM, and his areas of expertise within hematology is in both benign and malignant hematologies, but he's got a special interest, of course, in the malignant field, whereby he has special interest in lymphoma and myeloma, and as well as CAR T therapy. And today he will be giving us a talk on thrombosis as well as antiphospholipid syndrome. And I would like to invite him to present his presentation today.
Right.
How's yours?
Okay. Thank you, Dr. Veena. Thank you for the very kind introduction. Thank you for the college as well for inviting me today. I will go ahead and start with the topic given to me today to talk about thrombosis and antiphospholipid syndrome. A disclaimer here, the topic is actually quite big. Many areas to cover, but I'll try my very best to try to do it. But I'll just touch on the gist of it on thrombosis as well as APLS. I think the important parts of it. And then I've got a very interesting patient to discuss, and then we'll take the questions after it. Yeah. Okay. So without further ado, I'll start. Okay, so we will start with thrombosis, a bit about thrombosis, the pathophysiology, and so forth, and then after that we'll touch upon APLS. Yeah. Okay, so what is thrombosis? Just an overview for those, for everyone. Okay, basically, it's the process of formation of a solid mass in a circulation. Okay, basically from the constituents of the blood flowing. Okay, the mass itself is basically called as a thrombus, as you can see clearly described in the picture. Okay, so that is the clear definition of thrombosis. All right. Basically, don't get confused. Okay, basically we have to differentiate between what is called as a hemostatic plug and versus a thrombi. Hemostatic plug is something that is actually very useful. Basically, is used to stop the escape of any blood or plasma. Okay, so that's what we want, hemostatic plugs. Whereas thrombi, we don't want thrombi because it can be life-threatening. Basically, thrombi happens when there's an unruptured cardiovascular system, and that can be can be very life-threatening, and can be caused by two very harmful process, either ischemic injury or thromboembolism. Okay, so what is ischemic injury? Basically, the thrombi, okay, may decrease or stop the blood supply to the part of the organ or tissue and cause ischemia. And that basically subsequently results in infarction. That's ischemic injury. Thromboembolism basically means when there is a thrombus or part of it may get dislodged and be carried along the bloodstream and as an embolus and lodge in a distant vessel. Okay, so you have a thrombus, and then that particular thrombus gets dislodged, and that basically get carried away along the bloodstream and then gets lodged in a distant vessel. Okay, so now this is an ischemic injury. Okay, showing you basically a clot and then causing occlusion to the distal vessels. Versus a thromboembolism, basically you have a thrombus and a part of the clot get dislodged and moves, okay, along or through the bloodstream, which is called as an embolus, and gets lodged in a smaller artery, and basically reduces or blocks the flow of the blood. Now, let's look at the pathophysiology. Why does this happen? Okay, or basically what we call as thrombogenesis. Okay, the formation of thrombosis is called thrombogenesis. Thrombus formation is thrombogenesis. Basically, in human beings, we have an inbuilt system in which the blood remains fluid in state. Okay, and that's a normal process. Okay, and it basically guards the hazards of the formation of any thrombosis or hemorrhage. That is in the normal system. Okay, so we have got the normal physiological system where we prevent the formation of thrombosis and hemorrhage, where the blood is always in a fluid state. However, when there is an injury to the blood vessel, and that initiates thrombogenesis. So at any time there's a disruption in the flow or the normal blood flow of the fluid state, basically that leads to thrombogenesis or formation of new thrombus. Okay, so let's look at what we mean by injury to the blood vessels. What are the processes that involve in this? So I think this is a very basic triad that we have learned over our years in a medical school, basically called as the Virchow's triad. Okay, which comprises of three primary events. Okay, in the formation of thrombus. So as you all know, it's been described as number one, the endothelial injury, number two, altered blood flow, and number three, hypercoagulability. So these are the events that basically leads to a thrombus formation or thrombogenesis. Okay, so let's dive in and look into details of it. Now, thrombosis or thrombogenesis not only involves the Virchow's triad that we looked earlier, basically also causes the activation of platelets and the clotting system. Okay, so we'll look into that as well in the subsequent slides. Now, events leading into thrombogenesis or the formation of new thrombus basically involves five aspects. Number one, endothelial injury. Number two, the role of platelets. Number three, the role of coagulation system. Number three, alteration of blood flow. And number five, hypercoagulable state. Okay, so we know The Virchow's triad is true. Three things, three, which is number one, endothelial injury. Number two, alteration in the blood flow. Number three is hypercoagulable state. Plus, there are other components involving the platelets and also the coagulation system. So all in all, there are about 5 events that actually leads to the formation of a new thrombus. Now, it's important that we understand the pathophysiology, because then only we can understand what basically all the kind of risk factors that leads to a thrombus formation. Okay, so let's look into one by one. What is an endothelial injury? What do we mean by endothelial injury? Okay, now, before we look into the pathology, we look into what normally happens. Okay, so in a intact endothelium, basically there are three processes that happen. Okay, there are three normal processes that happen in an intact endothelium. Okay, number one, basically it helps to protect the flowing of blood from any thrombogenic influence of subendothelium. Number two, basically, it releases antithrombotic factors. We have a couple of antithrombotic factors, for example, heparin-like substances. Okay, we have thrombomodulin, okay, inhibitors of platelet aggregation, and also tissue plasminogen activators. So basically, these are all antithrombotic factors. Okay, and number three, an intact endothelium basically releases prothrombotic factors, okay, which have basically procoagulant properties. Okay, for example, thromboplastin or tissue factor, basically which are released from the endothelial cells. We have von Willebrand factor that causes adherence of platelet to the subendothelium. We have platelet activating factor, which is activator and aggravator of platelets, and inhibitor of plasminogen activator that suppresses the fibrinolysis. This is in an intact endothelium. Okay, this is a physiological process that happens in an intact endothelium. Now, what happens when there is a vascular injury or an endothelial injury? Basically, what happens is it exposes the subendothelial extracellular matrix, or the ECM, okay, which is very thrombogenic, and it plays a huge role in initiating thrombogenesis or the formation of thrombocils. So any form of endothelial injury basically happens, which is a major significance in formation of arterial thrombi, especially in the left ventricle. Okay, so now any form of injury to the subendothelial extracellular matrix leads to or triggers the formation of thrombogenesis. Okay. So let's see, what are there are a couple of factors and conditions that can cause. So what causes vascular injury? Okay, so we spoke about number one, endothelial injury, vascular injury. So what factors basically causes vascular injury or basically predisposes the formation of thrombi? So when we look at what are the possible factors that leads to the vascular injury, number one, we have a couple of factors. Number one, ulcerated plugs, okay, especially in patients with advanced atherosclerosis. Number two is basically hemodynamic stress, especially in patients with uncontrolled or severe hypertension. Number three, arterial diseases. Number four, diabetes mellitus, and subsequent basically endogenous chemical agents such as hypercholesterolemia or dyslipidemia, and also endotoxins. And also we have got exogenous chemical agents such as cigarette smoking, and of course the latest is vaping. So these are the processes or factors that predisposes or conditions that causes vascular injury, and that leads to the formation of new thrombus or thrombogenesis. Okay. Now, this is an example cartoon showing us what we mean by an ulcerated plug in patients with advanced atherosclerosis, okay, basically leading to a endothelial injury, and that leads to the formation of thrombogenesis. Here, basically, in patients, in someone with uncontrolled hypertension or prolonged severe chronic hypertension, leading to a couple of mechanisms, basically increase in blood flow, causing shear stress, okay, and that leads to endothelial injury, and that causes the formation or increase in the risk of developing thrombogenesis. Now, I was mentioning to you about endogenous toxins, which is hypercholesterolemia, the deposition of cholesterol lipids in the subendothelial area of the blood vessels, leading to the formation of thrombogenesis as well. Okay, so these are a couple of risk factors or conditions that predisposes to vascular injury, leading to the formation of thrombogenesis. Okay. Now, the second pathophysiology that leads to thrombogenesis is the role of platelets. Okay, as we all know, the moment there's an endothelial cell injury, the platelets basically come to play. What do? They help in the normal hemostasis as well in thrombosis. There are a couple of sequence of events that actually happen. Basically, number one, platelet additions, platelet release reaction, and also platelet aggregation. Okay. So basically, in terms of platelet addition, two important factors that actually involved is number one, glycoprotein 1b, and also the von Willebrand factor. The glycoprotein 1b, which is the receptor on the platelet, basically recognizes the site of the endothelial injury, and the circulating platelets adhere to the exposed subendothelial ACM. Okay. And the von Willebrand factors, basically synthesized by the endothelial cells, binds the GP1B and forms a firm addition of platelets with the ECM. Okay, this is regards to platelet additions. And basically, deficiency of VWF leads to von Willebrand's disease, and then the absence of GP1 leads to Bernard-Solier's disease. Okay, which eventually results in defective platelet addition and causes abnormal bleeding. Now, platelet release reaction, we discussed about it earlier. Okay, so this also plays a role in the thrombogenesis. Now, this is platelet aggregation, okay, and this also plays an important role in the formation of thrombogenesis as well. Now, the third factor that basically plays a role in thrombogenesis, as I mentioned earlier, is the role of coagulation system. Okay, so basically, coagulation system is a very complex system. Okay, and the mechanism here is to convert, in normal circumstances, is to convert plasma fibrinogen into a solid mass called fibrin. Okay, so you have soluble fibrinogen causing insoluble fibrin. Okay, as we all know, the coagulation pathway is basically divided into two, or we have got two pathways, basically the intrinsic pathway and also the extrinsic pathway. And these are very complex pathways causing or basically helping in the coagulation, hemostasis, and so forth. Okay. Now, the regulation coagulation system, basically, normally the blood is kept in a fluid state, and the coagulation system basically kept in check. And this is basically under a couple of factors such as the protease inhibitors and the fibrinolytic system. Okay. And basically, when there is any defect or any upregulation of this coagulation system, that basically increases the risk of thrombogenesis. Now, the other factor that basically affects or helps in the thrombogenesis is basically the alteration of blood flow. Okay, so basically we know normally there is always an axial flow of blood, okay, in which most rapidly moving central stream consists of basically the leukocytes and also the red cells. The platelets are present in the slow-moving laminar stream, which are adjacent to the central stream, okay, while the peripheral stream consists of most of slow-moving cells, such as the plasma close to the endothelial layer. So at any point, this axial stream is being disrupted, for example, due to turbulence or stasis, that leads to thrombosis, okay? And that basically leads to the formation of new thrombus. So I was mentioning to you earlier, the normal flow is basically laminar flow, and in any circumstances where there are any thrombosis or due to disruption of any the normal flow of the blood, basically leading to turbulent flow, that causes new thrombus formation, which is thrombogenesis. Now, the last pathophysiology that basically leads to the formation of thrombus is hypercoagulable state or thrombophilia. Basically, these are groups of conditions where or patients having increased risk of predisposition to develop venous thrombosis. And basically, this condition can be either hereditary or primary, or it can be an acquired or secondary. So when we talk about inherited or primary factors, basically you have got deficiency in antithrombin 3, deficiency in protein C, protein S, mutation in factor V Leiden, and the others as well. In acquired or secondary causes, there are other things, for example, secondary to conditions that basically leads to hypercoagulable states, such as risk factors, example, patients who are in advancing age, prolonged immobilization, cigarette smoking, and of course, obesity. Okay, and there are also other predisposing clinical conditions, for example, in heart conditions, myocardial infarction, rheumatic mitral stenosis, cardiomyopathy, vascular diseases, okay, patients with hypercoagulable conditions such as polycythemia, MPN, myeloproliferative neoplasm, shock, tissue damage, late pregnancy, and certain drugs as well. And of course, what we're going to look today, we're going to discuss later, is basically the presence of antiphospholipid antibody leading to antiphospholipid syndrome. Okay. Now we looked at what is the pathophysiology or how thrombogenesis happens or thrombosis happens. Okay. So now we look at the different types of thrombosis. Okay, so thrombosis is normally categorized by where it occurs in the body. Within this category, it can be either classified as venous thrombosis or arterial thrombosis. I think this is something that we are quite familiar with. There are a couple of different types of thrombosis, either venous or arterial, okay, depending on where it actually occurs. So this is a very clear diagram or table showing us the difference between an arterial thrombosis or a venous thrombosis. I would like you all to focus on the thrombogenesis. Basically, in arterial, it's because of endothelial cell injury, versus venous thrombi is due to venous stasis. Okay. Now, so mural thrombi basically is non-occlusive that occurs in an arterial thrombi. Basically, it adheres to the wall of the blood vessel, versus an occlusive thrombi, which happens in a venous or a venous thrombosis. Basically, it is a thrombus that completely occludes the blood vessels. So we have a mural thrombus or an occlusive thrombus, okay, occurring respectively in an arterial or in a venous circulation. So now I think we are very, very familiar with something called DVT, deep vein thrombosis. As you can see, this cartoon basically showing us what is a normal blood flow in the first diagram on your left-hand side, and the subsequent diagram in the middle shows what is a deep vein thrombosis, basically a clot formation in the venous system. And part of the clot, when it gets, or part of the thrombus, when it gets dislodged and it basically propagates or starts moving, propagates or starts moving as an embolus, and that basically can then cause occlusion to other distant vessels. Okay. So basically, I'm coming to the summary of thrombosis, the first part of my talk. Thrombosis or thrombogenesis is the formation of thrombus, as we have clearly or quite lengthily discussed about the pathophysiology, where basically is related to one or more components of the Virchow's triad. Okay, but there are Virchow's triad is 3, which is the endothelial injury, abnormal blood flow, hypercoagulable state, plus you have the platelet function and also the coagulation factors getting involved. So there are basically 5 factors or conditions that basically leads to the thrombogenesis or thrombus formation. Okay, so I think we had a look at it clearly. Endothelial injury, you have got a couple of ways or conditions that can predispose to an endothelial injury, as we discussed clearly earlier. Now, when this thrombi may propagate, may resolve, or become organized or embolize, and that can start propagating, and that can lead to occlusion of distant vessels. Okay. Thrombosis causes basically tissue injury by any local vascular occlusion or by distal embolization. Okay, so therefore, identifying a thrombosis, basically identifying a thrombosis is important. Identifying the risk factors in someone who will develop thrombosis is also very, very important. Okay. Now, I'm not going to talk much about the treatment of thrombosis. I think that is very clear, and that will take another a long chapter to discuss about the treatment of thrombosis. I will now dive in straight into APS, or antiphospholipid syndrome, which is the second part of my talk. And this is basically related to the first part of thrombosis as well. All right. Now, when we talk about antiphospholipid syndrome, it's a very complex condition where it's a heterogeneous disease involving clinical and also lab parameters, and it can involve a wide range of population. All right. Now, before I speak on the theory part of antiphospholipid syndrome, let me share a interesting case that we managed many years ago in the place of practice, in my place of practice, and just to highlight to you how antiphospholipid can or may present differently, not as straightforward as we usually see. Yeah. So this is basically a very interesting hypercoagulable state in a patient who presented to us for other reasons, for other presentation, and then subsequently referred to us for this symptoms. So basically, I have a 25-year-old male. He was admitted back in 2019. At that time, his presenting complaints were breathlessness for a year. He had fever for a week, and also complained of pain and discoloration of his toes for the last 3 days. What actually brought him to the hospital was basically his pain and also the discoloration of the toe, which was very acute. That was basically his main complaints when he presented to the hospital. At that time, his breathlessness was basically insidious in onset, very slow progressive, and that was basically for the last 1 year. And now here we're talking about a young gentleman coming with breathlessness for a year. He denied any history of palpitations or pedal edema, okay, no cardiac involvement. At the same time, he complained of fever for a week. According to him, it was high grade, continuous fever, but denied any chills or rigor. He had cough with expectoration, which was mucopurulent, non-foul smelling. Denied any episode of hemoptysis. He did mention about giving a history of loss of weight and loss of appetite. He also complained of having pain on both the lower limbs. Right was more prominent compared to the left. And what was most striking was the brownish black discoloration of his second and third toes of his right leg. So he also had complaints of cramps in these lower limbs with claudication pain as well. He denied any history of any joint pains, swellings, deformities, or any morning stiffness. Subsequently, he also gave us a past medical history where he was actually treated for pulmonary TB in another center, and he was given anti-TB treatment twice for the past 2.5 years. I'm not too sure whether there was any resistance, history of resistance, but he was treated adequately. He actually was on, in the last 1 year, because of the breathlessness and cough, he had seen a couple of doctors, and he was treated for bronchiectasis. Family history, no other similar complaints among family members. his second in the family. On examination, basically patient is conscious, he's orientated but extremely emaciated. Basically, he had lost drastic loss of weight and appetite. He was pale looking. He had grade 2 clubbing. He had right forefoot gangrene. The discoloration of the second and third toe on the right foot basically showed gangrene. And his skin of his lower limbs were actually very dry, scaly, and atrophic. He denied any rash. There was no deformities of any joints involved. His pulse rate was 70 beats per minute, regular, absence of any pulsation in the right lower limb, in the femoral, popliteal, dorsalis pedis, and posterior tibial. The pulse was actually quite feeble in the left lower limb. Otherwise, the blood pressure was 130, 180. CVS, unremarkable except for loud P2. Abdominal examination showed soft, no organomegaly. His CNS examination basically showed generalized wasting of all muscles, upper limb and lower limb. He had no meningeal signs. His respiratory system, trachea was central. Basically, he had a lot of inspiratory creps at both the lower lung fields and presence of bronchi as well. At that point, he was given a diagnosis of bronchiectasis and probably a reactivation of old TB and also gangrene of the second and third toe, unsure what's the etiology. Basic blood test was sent. Basically, he had anemia 10.8. White cell was elevated 8.4. White cell was 8.4. ESR, that's supposed to be 102. Elevated platelets. He had thrombocytopenia. The others were unremarkable. This is his chest X-ray, basically showing some multiple opacity seen in both lung fields. Ultrasound abdomen, his liver was normal, kidneys were normal, echo, otherwise with some evidence of right ventricular hypertrophy. Sputum basically showed some pseudomonas. Sputum AFB was negative. Now, what I wanted to highlight here is, if you notice, his APTT was prolonged. Now, subsequent other blood tests were done. His rheumatoid factor was elevated. CRP was also elevated. And because of the isolated APTT, sorry, I didn't show the mixing test results. He was basically showed the presence of inhibitors, so he was subsequently sent for antiphospholipid, where the anticardiolipin antibodies were elevated. The IgG and IgM were both elevated. Now, patient, based on these results, he was actually started on a low molecular weight heparin and also a low dose aspirin as well, antiplatelet, and he had a vascular referral done. Basically, their impression at the time was primary hypercoagulable state with right iliac artery occlusion and a left temporal artery occlusion, suggest to continue the low molecular weight heparin and to do a CT angio at this point of time. And he had symptomatic improvement. Both the fever and the breathlessness improved, but subsequently developed right lower motor neuron palsy, seventh nerve palsy during the hospital stay, and had a bit of headache. At this point of time, there was a thought of him having a TB meningitis as well. So he was started on prednisolone 1 milligrams per kg per body weight, and he developed multiple cranial nerve palsy over the next 2 days. And so basically, the neurologist had seen the patient. He had multiple nerve involvement. And the impression at the time, basically, he had miliary TB with basal meningitis and small fiber neuropathy. He also had, so the physician at that time, the impression was rheumatoid arthritis with interstitial lung disease with reactivation of tuberculosis. So CT angio was done, basically showed extensive stenosis involving the arteries of the lower limb. the proximal celiac artery, right common iliac artery, long segment great stenosis exclusion of the right distal external iliac artery, extending into the common femoral artery, occlusion of the right popliteal artery, and so forth. So you had an extensive occlusion of the arteries. So in conclusion, so you have a gentleman, a young gentleman who had previously treated for TB, now comes in with a reactivation of his TB disseminated to his CNS with an underlying rheumatoid arthritis, a rheumatoid-related interstitial lung disease with a secondary antiphospholipid syndrome, which was complicated or presented with a gangrene toe, and on scan showing multiple extensive arterial thrombosis. All right. So now that I've shared a interesting case with you, we will dive into the topic. So basically, I will talk about antiphospholipid syndrome, the definition, the pathogenesis, the diagnosis, the classification criteria. I think this is very important. Basically, we have got something called seronegative or non-criteria APS. And we will talk about the different types of APS, which is the thrombotic obstetric APS and also CAPS, catastrophic APS. And I think the dilemma or the challenging question here is the use of DOACs in APS as well, and a bit about peripartum anticoagulants, and of course the conclusion. Now, basically, APS is an acquired autoimmune disorder that basically manifests clinically as a recurrent venous and or arterial thrombosis and or fetal losses. Okay, so clinically, you can have someone with recurrent venous or arterial, either or venous or arterial involvement or fetal losses. And so there are two components to APS. One is the clinical component. Number two is the lab component. So in terms of the lab component, basically elevated levels of antibodies directed against the phospholipid factors. Okay. So it basically mainly affects the women, okay, in their childbearing age. And it can either occur as primary or secondary, as we saw, to other rheumatic or autoimmune disorders such as SLE. So the previous case that we discussed, this gentleman basically had rheumatic. So now let's just very briefly look at the pathogenesis. So now this is divided into two, like I mentioned to you earlier, thrombotic APS and also obstetric APS. So now thrombotic APS, the problem here is the antiphospholipid antibodies. So when you have the presence of these antibodies binding to the phospholipids, basically these antiphospholipid antibodies, they bind to the endothelial cells and platelet, okay, and that leads to the when they bind to the beta-2 glycoprotein, the prothrombin, the protein C and protein S, and that basically interferes with the coagulation cascade. Okay, that basically reduces the activity of protein C, antithrombin 3, fibrinolysis, and tissue effector activity. Okay, and that leads to the formation of thrombosis. Okay. Now, when you look at in terms of obstruct APS, the antiphospholipid antibodies basically activates the complement on the cell surface, okay, and that leads to neutrophil and monocyte activation, which then releases, okay, reactive oxygen species such as TNF, and also TNF, anti-angiogenic factors, and also tissue factors, and that basically leads to placental injury, IUGR, and also fetal loss. Okay. Now, the diagnosis is very, very important, okay, because the diagnosing APS is never straightforward, okay. There are many challenges involving the diagnosis of APS. One of the first few diagnostic criteria, which was developed in 1999, subsequently was revised in 2006. You have the revised Sapura classification in 2006. And of course, now we have the latest classification, ULA classification in 2023, giving a clear definition of how to diagnose a patient of APS. However, there are still some gray area in the definition and classification of APS. Now, when do you suspect APS? Do we suspect APS in every patient? So there are certain groups of patients that are or have increased risk of developing or increase in the risk of developing APS, and these are the group of patients that we should subject for a antiphospholipid antibody testing. Okay, so let's look into who are the group of patients that we should do or practice antiphospholipid antibody testing. For example, in someone who comes in with the presence of deep vein thrombosis or pulmonary embolism in young people, okay, without any risk factors, basically having any unprovoked risk factors that especially in young people who actually develop any form of arterial or venous thrombosis. Number one. Number two, any form of thrombosis occurring at any atypical sites, okay? Atypical sites or having recurrent or multiple extensive thrombosis. For example, that gentleman that we mentioned earlier who had multiple extensive thrombosis, okay? Number two. Number three, in a young patient who comes in with or basically young stroke, anybody who's less than 50 years of age coming in with cerebrovascular accident or transient ischemic attack, these patients should be screened for APS. Any patients who develop thrombosis who have an underlying SLE or other autoimmune disease, especially SLE or rheumatoid arthritis. Okay, and also patients who have got recurrent abortions or associated obstetric complications. Patients who have got unexplained thrombocytopenia. Okay, so if you've got any group of patients who have got unexplained thrombocytopenia, they are basically patients who should be screened for APS. And also patients who present with any skin-related conditions such as livedo reticularis racimosa. Okay, so these are the category or group of patients that should be screened for APS. Now, the revised SAPURA classification, like I mentioned to you earlier, basically divides into lab criteria and also clinical criteria. The clinical criteria, thrombotic events, clearly described here, gestational events as well, and the lab criteria, basically anticardiolipin antibodies, lupus anticoagulants, beta-2 glycoprotein 1, IgG or IgM. Okay. And most importantly, this should be repeated at least 2 samples or 2 assays at least more than 12 weeks apart or interval. Okay, that is very important. Now, looking at the EULA classification 2023 is very, very clear here. Basically, it differentiates between clinical domains and also the lab domains. As you can see here, you have got the venous thromboembolism, you've got the arterial thrombosis, you've got the microvascular involvement. Here, if you look in the small box over down here, it clearly describes what are the microvascular involvement, suspected, established, very clearly described in terms of what could be the possible presentations of a microvascular involvement. Of course, established carries a heavier point. Then you have got obstetric parameters. Okay, someone with preeclampsia, severe preeclampsia, or also plays a higher grading point as well. And cardiac valve, okay, thickening and vegetation, and also thrombocytopenia. If you notice here, in terms of venous thromboembolism and arterial thrombosis, someone without any risk of VTE actually carries a higher risk. Okay. And when you look or focus on the lab domains, basically looking at the lupus anticoagulant and also anticardiolipin antibody and the anti-beta-2 glycoprotein 1 positivity as well. Okay. Now, now that we have looked at the classification quite in detail, let's look at how the thrombotic manifestations can basically present in this group of patients, basically in extremities, in the venous, arterial, in the liver, anywhere it can happen, throughout the whole body, in the central nervous system, in the lung, in the kidney, in the skin, and the eyes. What I would like you to focus in these three star points below, basically, triple positive is associated with fourfold increase in the risk of recurrent thrombosis. Somebody with a anticardiolipin IgG or a beta-2 glycoprotein is more pathologic than a IgM positivity. And venous thrombosis are more frequent than the arterial thrombosis. Okay, so these are the important points to consider. Now, in terms of obstetric antiphospholipid syndrome, it can happen at preconception. What happens during pregnancy and fetus and also infants? Okay, as you can see, the consequences is actually quite drastic. And if you notice, pregnancy morbidity rate in women with obstetric antiphospholipid is around 30%. And patients who have, or pregnant women with antiphospholipid syndrome with pulmonary arterial hypertension, the mortality rate is about 43%. Okay. So the mortality rate is almost half. Yeah. Now, this is a very interesting diagram just to illustrate again the manifestations of antiphospholipid. As you can see, it can involve any part of the body from head to toe. And it's color-coded, as you can see, basically some frequent incidents, less frequent, unusual, and rare. And frequently, as you can see, it can lead to stroke, pulmonary emboli, pregnancy morbidity, libido reticularis, thrombocytopenia, and DVT. So these are all common occurring clinical manifestations in someone with APS. Okay. Now that we have looked into the clinical criteria or the lab criteria of antiphospholipid, we also have got other conditions which do basically classified as non-criteria features. Number one, thrombocytopenia, hemolytic anemia, libido reticularis, cardiac malvegetations, renal thrombotic microangiopathy. Previously, this was classified as non-criteria features. Yeah. There's something called a seronegative antiphospholipid syndrome. This is basically in patients where they have got the clinical manifestations and they are highly suggestive of APS, but persistently negative conventional antiphospholipid antibodies are basically negative, and these are basically classified as seronegative antiphospholipid syndrome. Unfortunately, this group of patients tend to have increased risk of developing thrombosis, okay, or recurrent thrombosis. So these are basically different ways or methods or other phospholipid antibodies that or enzymes or factors that we can do to basically diagnose non-criteria APL. So now let me speak about the management of APS in brief. Yeah. So basically risk factors for VTE, which includes age, immobilization, injury or surgery, pregnancy, birth control pills, oral contraceptive pills, being overweight or obese, smoker, cancer, heart failure. Then you also have got other major risk factors for developing CVD, such as age, the gender, high blood pressure, smoking, dyslipidemia, and diabetes. And then now there is a scoring system, basically the adjusted global antiphospholipid syndrome score, basically telling us what are the probability of someone developing APS as well. Now, the overall principles in treating APS, number one, is to determine the presence of a high-risk antiphospholipid profile, any history of previous thrombotic or any obstructive APS, basically the coexistence or other systemic autoimmune diseases such as SLE and the presence of any other traditional cardiovascular risk factors. To determine all those parameters. Number two, basically to screen and also strict control of any cardiovascular risk factors. Okay, for example, all those that we have discussed earlier. And also treat the treatment adherence, okay, INR monitoring in patients with who are taking warfarin, and the other subsequent therapies in somebody with APS. Okay. Now, in the recommendations, when we look at the recommendations for primary thromboprophylaxis in APL positive subjects, basically in a asymptomatic APL carrier, that means they don't have any vascular obstructive APS criteria, a high-risk APL profile, or without any traditional risk factors, a prophylactic treatment with low-dose aspirin is recommended. In patients with SLE and no history of thrombosis or pregnancy losses, in patients with high-risk APL profile, is recommended for prophylactic treatment with low-dose aspirin. However, in patients with low-risk APL profile, prophylactic treatment with low-dose aspirin may be considered. Okay. Now, in terms of secondary thromboprophylaxis in APS subjects, in patients with a definite APS and a first venous thrombosis, the recommended treatment is with vitamin K antagonist and a target INR of 2 to 3. Rivaroxaban should not be used in a triple positive APL due to the high risk of recurrent events. DOACs, however, could be considered in patients not able to achieve a target INR despite a good adherence to a vitamin K antagonist or those with a contraindication for vitamin K antagonist. In patients with unprovoked first VT, anticoagulant should be continued as long-term. This is for unprovoked VT. However, in patients with provoked VT, anticoagulant should be continued for 3 months. Longer anticoagulant subsequently can be considered, especially in patients with high-risk APL. Now, in patients with definite APS and recurrent venous thrombosis, despite on a vitamin K antagonist and the target range of 2 to 3, what do you do? Then again, look for the compliance to vitamin K, and if they have actually achieved a target of 2 to 3, then we can basically add on a low-dose aspirin, increase the INR target to 3 to 4, or change to a low molecular weight heparin. Now, in patients with a definite APS and a first arterial thrombosis, the treatment recommended is to treat with a VKA over a treatment of low dose aspirin only, and the target should be 2 to 3. Basically, rivaroxaban should not be used in patients with a triple positive, as I mentioned earlier, because the risk of recurrent thrombosis is higher. Now, so I think this we have touched upon earlier. So basically, in patients with individuals with obstructive APS, it can be separated into 3 different clinical phenotypes: those with pregnancy losses, those with previous complications of placental insufficiency, and those with previous maternal thrombosis. Okay. This is a clear algorithm basically showing a management of obstructive APS. I won't go through the details of this. Now let me just talk about catastrophic APS very quickly. It is a very severe fatal disease. It basically represents quite an extensive, a small amount of cases, probably about 1% of the occurrence of APS. However, the mortality rate is very, very high. It can reach up to 30%. Basically, how do you diagnose someone with CAPS or catastrophic APS? Basically, it involves 3 or more organs, systems, or any tissues, involvement of many manifestations in less than a week. And there is a histological confirmation of small vessel occlusions in at least one organ or tissue with a APL positivity. Okay, the pathophysiology of CAPS, still not too sure. However, basically what is happening here is there is an overproduction of cytokines, and basically there is a thrombotic storm in the microcirculation. Okay. So CAPS can actually occur as a primary manifestations, or it can occur along with the APS in somebody who already has got APS. So this is basically the management of CAPS. So just to highlight here, the first line of treatment is combination therapy with glucocorticoids, heparin, and also plasma exchange, or IVIG. And also for patients who have got refractory CAPS, then the physician can consider giving a B-cell depletion such as rituximab, complement inhibitions as drugs, and so forth. So now the controversy or the use of DOACs in antiphospholipids. So these are basically some of the papers, but these are all very old papers. There are new advancements. Basically, DOACs appear to be more safe and effective in the treatment of APS, but then again, you need more data to confirm this. But then again, it's contraindicated in the use during pregnancy. But nevertheless, more and more data are coming out in the use of DOACs in this category. But however, vitamin K antagonist still remains the main choice of use in APS, especially in patients with triple positive or recurrent thrombosis. So this is a very substantial, comprehensive algorithm in the treatment of APS. In terms of venous thrombosis, arterial thrombosis, obstetric thrombosis, as you can see on your left-hand side. So it's divided into someone who has got previous history of thrombosis. If yes, depending on which side is involved, whether it's a venous, arterial, or obstetric thrombosis. And if someone who's got no previous history of thrombosis, whether they are pregnant, not pregnant, and then subsequent, the algorithm follows. So I'm coming to almost the end of my slide. Sorry, due to time, I'm rushing a little bit. Every patient should be basically instructed to avoid risk factors. I think that we went through earlier, the cardiovascular risk factors, basically to avoid smoking, control the obesity, and all the other risk factors. The use of oral contraceptives should be used cautiously in this group of patients, and they should be recommended for other modes of contraception. Patients who are taking vitamin K antagonists should receive vitamin D, calcium supplements in addition to a PPI, basically to reduce the risk of osteoporosis and GI bleed, and also which are associated with the prolonged use of oral anticoagulants. Thank you so much for listening to my speech, to my talk today. I'm happy to take in any questions.
Thank you, Dr. Siva, for the very elaborate and extensive explanation on thrombosis as well as APLS. We have one question here in the chat box, and the question actually goes like this. What would you say if a patient with antiphospholipid syndrome who has pulmonary artery hypertension, is there any contraindication for pregnancy?
So I think I just I just shared the data just now. I mean, the mortality rate, there are many studies. There's some studies to say that the mortality rate is up to 60%. Some data say is up to, but the average mortality rate is about 43%. But of course, I think now with the newer and newer technologies, modalities, and so forth, the mortality rate is actually reducing. However, it still remains high. And there are physicians who actually say this patients who are basically having pulmonary hypertension should prevent or should at least try not to get pregnant due to the risk of mortality being quite high. Yeah.
I suppose it's always on a case-to-case basis, right? But
True.
depending
Depending on how bad is the pulmonary hypertension as well, I guess.
So
Yeah.
I think the right answer, not to say the right answer, but the how to say the most diplomatic answer probably would be that probably need to have an MDT, discuss with
Yes.
cardiologists to see how severe the pulmonary artery hypertension is, whether there is what is the risk that is involved during the pregnancy state and stuff like that. So a multidisciplinary team, including COAG and stuff like that.
Sure. Yeah.
But I would have to say it's very difficult. And I think not just the pulmonary artery hypertension, but managing thrombosis itself or prevention of thrombosis during pregnancy can actually be quite difficult. We also have a few other questions. So let's just go through them. So is warfarin contraindicated in pregnancy? Oh no, it says actually the statement is warfarin is contraindicated in pregnancy, hence need to change to Clexane throughout the pregnancy. Is that I'm not too sure whether it's a question or a statement. What is your take on that?
Yeah, I mean, we know that vitamin K antagonist is actually contraindicated in pregnancy. So that's the reason why we actually convert these patients into a low molecular weight heparin. And almost invariably, postpartum, we then convert back them to a vitamin K antagonist. Yeah.
So I think perhaps it is it is definitely absolute contraindication during the first trimester because of its teratogenic effects.
Yep.
But you can use it in the second trimester and early third trimester.
Yeah.
Then eventually convert back to low molecular weight heparin so that it will be easier for you to manage the whole delivery process, so to speak. I think it's not an absolute contraindication, but I guess it's probably easier and we are more comfortable using low molecular weight heparin, I suppose, in this time and age. So the next question, for postpartum patients with APL antibody positive, what about the treatment options available for them? How long would these patients need to be on that treatment?
So I think this basically depends on the couple of things. I think the algorithm basically shows in terms of the previous history of thrombosis and also the positivity of how many antibody that is actually positive. That all depends on the whether these patients should be on a long-term anticoagulant and so forth. Yeah.
I suppose then it probably boils or falls back to your risk classification, right? So if they fall under the high risk category and then they've already had a risk of a history of thrombosis before, then I think you would probably want to put them on a longer term anticoagulation. But if it was only started for pregnancy purposes, then I think, and without any history of thrombosis and they're not high risk, then I think you should at least continue for the first 6 weeks, the 42 days, the postpartum, and then eventually, you may stop if there is no history of thrombosis out of pregnancy and it was only given during the delivery process as primary prophylaxis. So the next question, APL patients with artery and venous thrombosis, do we consider combined antiplatelet and anticoagulant therapy?
Yeah, okay. So I think this is something that a lot of physicians and people ask whether, because the mechanism of action in terms of arterial and venous it's different in this point. So yeah, I don't know, Dr. Veena, what would be your thought?
I would say that it's no harm to add on. Also, once again,
depends on the risk of bleeding as well. So in the kind of patient that you're treating and the kind of risk factors that this patient has and the other, whether the patient has got any history of GI bleed, elderly patients, risk of fall and things like that. So then again, you need to discuss with the family members, the caretakers and so forth. Yeah.
I suppose when there's a suspicion that anticoagulation alone may not function and the risk of thrombosis is high, especially arterial thrombosis, of course, bearing in mind the risk of bleed, there's no harm adding on an antiplatelet to that equation. The question is, if the patient is allergic to aspirin, can clopidogrel and any other antiplatelet therapy be used for APLS?
Yeah, can be used. Shouldn't be a problem.
Yeah. So I think the only contraindication or the only question is what type of anticoagulant that you use.
Yeah. I think antiplatelet is not a problem. It's the more of the anticoagulants,
So it can be used. Finally, if a patient needs to be on DOAC due to contraindication to warfarin, what is the best option of DOAC and any?
Anyway, to choose. I think there is no real data or trial or study that has been done looking at all the different types of DOAC in terms of in the use of APLS. I think the one that they have kind of suggested is Xarelto. But then again, we still need more data on the use of DOAC in this group of patients. But like I said, it's a big no for patients with a triple positive and a recurrent thrombosis. DOAC is still not an option. Warfarin is the way to go for this group of patients.
Yeah. So I suppose those with very high risk triple positivity, no, but DOACs have. I mean, there is a study on rivaroxaban, so Xarelto, yes. And I suppose if you have no choice and you have got difficult achieving INR, then that is an option to give your patients. I think this question we've answered already. Which DOAC is preferred? We know. Which DOAC is preferred if it was used for APL with no thrombotic event previously? Now I'm wondering, why would you give anticoagulation to person? So I must, you want to answer this, Dr. Siva?
Sorry, Dr. Vina.
So it says that which DOAC is preferred if it was used for APLS with no thrombotic event previously.
Oh, okay. I think the algorithm is quite clear in terms of this group of. It depends on. Then again, we look at the risk factors involved in terms of the positivity. How many antilipids are actually positive? The history of any. Also, these patients had never had any history of thrombosis in the past. But then again, we look at all the other cardiovascular risk factors as well and so forth. Then we decide on the kind of treatment that we give. So Dr. Vina, you want to add on anything?
Yeah. So basically, what do you call this? I suppose the only reason why we want to use a DOAC, in a patient who has not, anticoagulate a patient who has not had before. I'm assuming it is for prophylaxis.
Yeah.
Rather than a treatment dose. And usually, technically, if you want to give prophylaxis, then I suppose there's no real. I would probably use low molecular weight heparin if it's going to be for temporary reasons, unless you're planning to put the patient on anticoagulation lifelong for a person who has not had thrombosis. I'm not entirely sure for that. So that is a bit difficult to answer. Maybe whoever will ask that question can maybe PM the P, and maybe we can have a subsequent follow-up discussion on that.
Yeah.
Okay, so the next question is, do we really need to repeat APLS antibodies 12 weeks later if clinically suggestive, especially if it is an unprovoked VTE, single high anticardiolipin antibody or a high anti-beta-2 glycoprotein antibody?
To repeat antibody again, 12 weeks if clinically suggestive. I guess because if you look at the classification criteria, first test has got a certain amount of points, carries a certain amount of points, and then if you have repeated the test, and if it's persistently positive in the second round, it carries a higher value. So I guess that's the reason for repeating the test the second time as well. So I would still repeat after 12 weeks. Yeah.
I think the main question to ask is, would it change your management?
Yeah.
if that comes back as negative, would you then stop anticoagulation? Perhaps the answer would be no, because I don't know. I mean, it all depends. Once again, it would need a discussion with the patient and stuff like that. But
And also looking at all the other patient has got any previous history of any thrombosis, all the risk factors as well.
yeah, so I suppose if the clinical history itself is unprovoked and you already have one episode to say that it's probably APLS, if you repeat again and it becomes negative, are you going to change your management? I wouldn't change my management. So the question is, I may not even repeat to answer that question. Yeah. Any reason why antibody 12 weeks apart? This one is physiology. I suppose you are talking about antibodies, right? So sometimes the antibody, once it goes up, then it takes about 3 weeks, or it stays in the system for about 3 weeks. So about there lah. Not 3 weeks, 3 months, sorry. Reason why it's probably about 12 weeks apart. So once antibody titers come down, you want to make sure that whether it's still there as in a true positive, or it's not like a transient rise in terms of antibody. So some APLS patients have thrombosis, but they also have thrombosis. How to anticoagulate these patients?
Okay, so this is very interesting. So I just have a patient. I have a patient now in the ward. Gentleman 39 had a history of two vessel disease 5 years ago, had recurrent venous thrombosis in the lower limb. Now, just this 3 months ago, started having thrombocytopenia. He already had mild thrombocytopenia, and now the platelet is dropping exactly like this. Now, platelet is 50, between 60 to 50. So I guess first thing first, in somebody with APLS, I guess the occurrence of thrombosis here, it could be secondary to the APS itself, or it could be associated with ITP. I think that has to be clearly defined, whether the thrombocytopenia here it's secondary to the APS or it's a primary ITP. So once so somebody who comes with a secondary APS in this group of patients, the risk of bleeding is actually quite low as comparative to a primary ITP. So in my patient, it was a primary ITP. So I actually gave some amount of steroids, and that basically pushed up the platelets. And then I started the patient on anticoagulant. And he's also on an antiplatelet as well. Your thoughts, Dr. Veena?
So basically, we see this a lot in our patients. So I think the antiphospholipid antibodies present occasionally like an ITP.
Correct.
So essentially, but they are non-bleeder ITP because they are thrombotic by nature. So unless the platelet counts are very, very, very low, some of them do bleed. But if you have a patient who has got low platelets, non-bleeder, my advice it would be to give them, of course, look for antiphospholipid syndrome. But then eventually, if you already have antiphospholipid syndrome and you think that they need anticoagulation, as you mentioned, give a bit of steroids, the platelet will go up, and then you anticoagulate them. Can we screen for lupus anticoagulant in an acute event of thrombosis?
Okay, so this is something I think we have been scrambling to answer, because somebody comes to us with an acute thrombosis, and then you quickly rush and send the thrombophilia screen because you're going to put them on an anticoagulant, and then you never know whether you can actually stop the anticoagulant, and then you never know whether you can actually then check for a lupus anticoagulant. So I think you can treat, you can check, but as long as before you start the anticoagulant, yeah.
Yeah, so I think the thing is, because when we do lupus anticoagulation testing or lupus anticoagulant testing, it is a clot-based assay. So essentially, if you give anticoagulation, then that would affect the reading of the result. If you're not given anticoagulation at that point in time, then I think it's relatively okay to make an inference. But I think what would not be accurate is things like protein C, protein S, because it would be probably falsely low due to consumption. Those are proteins, whereas these are essentially more like antibodies. So even if you do like your beta-2 glycoprotein and your anti-cardiolipin antibodies, that should not really affect the level, so to speak. But then again, for lupus anticoagulation, you have to be very sure that it is not laced with heparin, so if the patient is not on treatment.
Best to be done before treatment, before you start the treatment.
Yes, correct. And even when you plan to repeat it 12 weeks later, if you do plan to repeat it 12 weeks later, you need to stop anticoagulation.
Yeah.
Give it some time, maybe about a week or
2 weeks apart. Yeah.
and then eventually, then only do your testing. Otherwise, you will still have perhaps false positive results. Okay, I think we have had we've 15 minutes past time. Had a good discussion. I think maybe I just have one maybe comment or question to your case. Did you think that man could have had a catastrophic APL by any chance because he had
Possible because he had multi-organ involvement. Yeah, I would assume, yeah, probably there could be a component of catastrophic APS. Yeah.
Those are actually quite difficult to treat and also quite bad. Anyway, I would say thank you very much. I probably will pass the mic back or whatever, my role back to Dr. Vidya for completing this. Thank you very much. Thank you, Dr.
Thank you, Dr. Veena. Thank you.
Thank you very much, Dr. Siva and Dr. Veena. And thank you very much to the audience as well for being very interactive. I think there's someone who posted a question, say, can we have the slides? So Dr. Siva, is it okay if I share your slides?
Yeah, sure, no problem.
Okay, so thank you very much, everyone. And join us next week again for the month of rheumatology with another interesting topic. Thanks and have a good weekend.
Thank you.
Thank you, Dr. Siva. Thank you, Dr. Veena. And thank you, Dr. Vidya.